And once you get drunk on the idea that this data is gold, you start gaining momentum. And that's what I see every day, which is pretty exciting.
Hi, I'm Caitlin.
And I'm Clarinda.
And this is Not Just Patients,
a podcast where we break barriers to meaningful patient involvement in healthcare.
Thank you so much for tuning in today. On this episode, we're going to be speaking to Jennifer Bright about patient-centered outcomes measures and defining value in terms of what matters most to patients.
Jennifer is President and CEO of the International Consortium for Health Outcomes Measurement, or ICHOM, a nonprofit that works with patients and clinical experts worldwide to define and deploy standardized tools to measure health outcomes that matter to patients. Prior, she held executive roles at the Innovation and Value Initiative, focusing on advancing patient centricity, transparency, and equity in health technology assessment at the Society for Healthcare Epidemiology of America and Mental Health America. Jennifer is also founder and president of Momentum Health Strategies, board chair, Mental Health America, and editor, American Journal of Accountable Care on the Journal of Patient Experience. She holds degrees in political science and public administration from Trinity University and George Washington University. Thank you so much for joining us, Jennifer. It's really lovely to have you here.
Thanks for having me.
So this is a pretty technical topic, I think, when we say we're going to be talking about outcomes measures. A lot of people listening in would not even know what that meant. So we're going to start at the very beginning, and maybe you can just define outcomes measures, when and how they are used, and everything that one would need to know to just begin listening to this podcast episode.
Thanks for this opportunity. One of my favorite topics, and especially my favorite audience, because I really believe that patients and families know this already, but probably the language sounds like it's a barrier. So when we talk about outcomes measures, these are things you as patients and families already know. It's about the results that you're getting out of healthcare. And outcomes measures, really, it's a scientific term, if you will, that refers to tools that have been designed by academics and clinicians to measure and be able to be compared. They could be surveys, they could be a lab results, they could be an input direct from the patient. Now we have wearables that can bring in your blood pressure or other things. Those are all metrics, measures that can tell us whether somebody is doing well. When we're talking about outcomes, it's not just clinical outcomes. So if you're diabetes, your A1C level, your sugar level. But outcomes are also how it impacts your life, your pain experience, whether you're able to walk after a hip replacement surgery. How is it affecting your mental health? If you're a mom and you have young kids and you're a cancer patient, are you able to play with your children? Are you able to care for them? It's what's the experience they're having with their health condition, both good and bad, and how are they progressing? And then the measures are about the tools we use to tell us, both the clinician and the patient, whether we're moving towards health.
That's really very simply explained. I think that makes it quite clear. And I think I kind of know the answer to this already, but what would you say are the kind of outcomes that have been measured more traditionally?
Yeah, so historically, and in most randomized controlled clinical trials, so the trials that are used to decide what new technologies come into the marketplace, whether it's a drug or a device, they typically look at things like survival or how long can we extend disease-free experience, because that's the goal of regulatory bodies. They want to know, is this drug or this device going to extend the life or cure the condition that the patient might have? The problem with that is that's kind of like one pinhole of the whole picture, right? And so we typically don't look at things like impact on pain, impact on mobility and functioning, impact on mental health. If you're taking a drug, does it make you gain 40 pounds? If you're using a device, does it cause pain in the site that was unanticipated? So that's why the balance point is both things together. It has to be clinical and the aspects of impact on life.
That makes sense.
So we're talking about patient-centered outcome measures as well. And you've kind of defined two sort of angles there, but where does that patient-centered angle kind of come in or overlap with those traditional measures?
Yeah, so it's a bit of a mindset, isn't it? I mean, from my personal journey and experience, patient-centered is the only way to think about it, right? The point of healthcare is health for the patient, getting people back to health. And not just survival, but health, meaning all its dimensions.
Right.
So when we talk about patient-centered outcome measures, to me, it's obvious that outcome measurement should be patient-centered. We've had to put that label on it to remind others that it's about the patient and not about scientific, interesting questions of comparability or proof of a new technology. Not that there's anything wrong with that, but the word patient-centered reminds everybody this is about the patient, how they define what dimensions of their experience are most important to them.
Interesting. So in a way, actually, there could be a lot of overlap because some of the standard measures you mentioned before about overall survival, progression-free survival, they're patient-centered in a way because that is also usually what patients want. They want to live. But it's about not looking at those one-dimensionally and also exploring for that specific patient community or individual, what else do they care about at the same time? And one kind of thought process around that is if you have two completely identical interventions, but one of them makes you live longer, of course you go for that one. But if one, you live 10 years longer, but you're bedbound and you can't speak, whereas the other, you can live 5 years as you usually would, then that's where it tips the balance. And that's why you kind of need that mix, maybe.
Right.
And yeah, because it generates information that wasn't previously accessible to patients, they can make that decision for themselves, right? So if all we're measuring in clinical trials and in research is survival, then the only data that available to you when you're talking with your clinician about a cancer treatment or whatever is survival. And we don't have any data to tell us what is the likelihood that this is going to make me bedbound or increase a risk of pain or force me to leave my job that I love. And so it hampers the ability of patients and clinicians to have a full conversation about what the choices mean and allow the patient to decide for themselves what's the balance they want. Just to use a very clear example, when both my parents had cancers, we didn't talk about the impact of all the treatments on our young family. We didn't talk about, no travel, loss of work, the role reversal that was going to happen from me being an 18-year-old to being a caretaker. Like none of that was on the table. There was no opportunity to have that conversation. It was just about survival. And that's why I'm really passionate about this topic, because we have the ability to measure things that are important to patients and families. And yet it's not a standard thing. It's not universal. And there's a lot of people who poo-poo it and say that's too hard. And I would argue, and hopefully your audience is hearing me when I say this, the patient community writ large needs to understand that they've always been championing outcomes. Every single one of you is striving to have the best life possible for your physical health, but also your total health. And this is a lever by which we command, if you will, the importance of the clinical and patient together making decisions that are about whole health. And yes, it's challenging, but it's not impossible. And I'm excited by that because we need to push for it. We need to say, this is the only way forward.
Yeah, that makes so much sense. And actually, it makes sense in all disease areas. But even in some of the oldest or largest disease areas which have had care for essentially a long time, diabetes, for example, for all this time, the main measure is blood glucose levels. And Caitlin has diabetes, so she can speak to this better. But perhaps patients really want to track things like whether they feel faint and how often they feel faint, and whether they're able to go and enjoy parties as opposed to just these things in their blood. And I think that all of this makes so much sense. I can hear the passion, Jennifer, and you did touch a little bit upon your personal story. So we'd love to hear more about that. Please tell us what brought you to this space and your motivations for this work.
Well, when I was in late college years, both my parents were diagnosed with stage 4 cancers within 2 months of each other and had major surgeries and whatever. And then we were on this 5-year journey of not knowing what was coming at us, but it was just all about survival. And ultimately, they had the worst outcomes. They both passed away at the age of 50, both of them. And in both cases, they were misdiagnoses that got us on that path. And this is a common story. Whether I've worked with rare disease patients, mental health, like any disease area I've ever had the privilege to interact with people who are experiencing it, we all have a similar story. It starts with a bad outcome. And we've made a lot of gains over the last 30 years, especially in the realm of understanding that patients are the biggest expert in the room. I mean, my journey professionally is in policy and patient advocacy, and that is born out of my experience being an observer and a participant, and in some ways a victim of the lack of patient centricity that existed at the time when my parents were sick. And I learned firsthand where clinicians don't listen to patients. I've witnessed it. I've witnessed using the most expensive technology and therapy on the market, and it is devastating in ways that you don't understand until you're in it. And so those imprinted on me. And what they imprinted was a notion that first and foremost, the patient and the family has to be the biggest self-advocate, right? And so as a patient advocate, that's what I'm passionate about, is helping patients and families feel empowered and able and equipped to demand what they need out of the healthcare system. And it's hard work. But when I started my career, I was working in mental health primarily. And at that time, I mean, it was whispered about. You would talk to policymakers, oh, that's psychiatry. No primary care physician would even discuss it. That's not my specialty. I don't know. We didn't talk about the fact that mental health is definitely tied to chronic illness, right? I witnessed that firsthand with my mom. And now it took a pandemic for us to actually talk about mental health. Before COVID, we were still in that state where mental health was separate. We were treating from here up and then the rest of the body. And we were doing things like, well, we have a shortage of care providers, so we can't provide care. We can't use telehealth to deliver mental health. That would be bad. And then we hit a pandemic, and suddenly we recognized that everybody has mental health needs. We realized that, oh, we can deliver care across boundaries using technology. What a concept. So there are so many things where if we'd stayed focused on what are the needs of the population that we're talking about, how do we deliver those outcomes to them, we would get past a whole lot of the 10 reasons why we can't do it. So that's my orientation, is not to say that we don't all have challenges we have to get over, but to start from the premise of, is this making the patient and family better? What's the benefit to them? That has to be the primary driving question. Otherwise, what the heck are we doing?
And it seems so simple when you say it like that, right?
Yeah, but that's my main message, is it is that simple.
Yeah.
We've made it complicated with whose measurement tool is better from a psychometric perspective, who has a right to use it with licensing barriers, who developed it. Is it suspect because a pharmaceutical company funded the work to create the tool? Those are all artificial barriers, because at the end of the day, if you measure the thing and you start looking at the data it generates and you start seeing how it transforms choice, it transforms patient engagement, it transforms clinical workforce satisfaction, it transforms outcomes, it transforms cost. I promise you, once you see that, you can't unsee it in a good way. And that's what ICHOM is about. And that's why I'm here and why I'm so enthusiastic about what it does, because yeah, it's complicated, but I see every day examples of where measuring the things that are important to patients and the clinical teams that are caring for them is transformative.
That's fantastic. And to have a measure for these kind of things as well means you have evidence, solid evidence that you can demonstrate, because, you know, mental health challenges existed before COVID, but no one was talking about it. No one was measuring it. So having that in place so that you can use that as evidence and reasoning to kind of overcome any barriers and highlight the issue is really important. And I wondered actually if you could tell us sort of from the back of that a little bit about your work with ICHOM and what you guys do.
Yeah, so ICHOM started out of an academic idea. We were founded in 2012, and it was a group of academics and clinicians, Michael Porter from Harvard University, who co-wrote this book with Elizabeth Teisberg called Redefining Healthcare. And their premise of that book was, we need to focus on patient outcomes. We need to focus on the whole person. We need to focus on measuring that and then bringing that data back into clinical redesign. So that was the original idea. But Michael and a clinician named Martin Ingvar from Karolinska Institute in Sweden, and Stefan Larsson, who also a clinician, but at the time was at a consulting firm called BCG. And so they got together and said, this is the right concept and this can fundamentally change healthcare, but we need a way to activate it. We need a centralized place that is the home for this idea and can put it into practice. And that's how ICHOM was born. And so the work that the organization has done over the last almost 15 years is first and foremost to gather clinical and patient and research knowledge and expertise and find consensus. That's the word consortium, right? We're bringing together an international community to agree on what are the most important dimensions of outcomes in a given health condition. And then within the literature, within clinical practice, what tools exist right now that we have available to us today to measure those things? And it's not a static thing, right? We also have to update this library. But the original purpose was to build what we call the outcome measure set. So essentially what that is a representation of all the aspects of health outcomes that are important to patients with diabetes, with irritable bowel disease, with cancer, with obesity. And then within those dimensions, what are the tools we have available to tell us that we can see progression towards better? And then we publish those. We put them in peer-reviewed journals. They are free to use. And then now I think we spend more time on the implementation side, working with clinics, hospitals, academic medical centers, governments, patient organizations to say, how do you use these tools in real life? And when you do, shine the light on the data that it generates and how it fundamentally changes the way care is being delivered. So we're not just an academic idea, we're science in action. And the thing that clinched it for me when I was exploring joining ICHOM was the involvement of patients. You can't do policy without us, right? Nothing about us without us. But the process of ICHOM's work has always involved people with lived experience. And I'm not only proud of that, but we're actually pushing the envelope on it. So when we impanel working groups, we are using a wide variety of methods to find people who are living with that condition and bringing them onto the working group. But they're also co-authors on the paper. So patients then are getting published. We are working with patients to disseminate this information, to champion the use of it in the real world. So we involve patients at all levels of our work, which I'm very proud of. And actually, the two newest sets that we're developing, one in spinal muscular atrophy, which is a rare disease, and also bladder cancer, these are the first two working groups that have co-chairs who are patients.
I love that. Yeah.
So I want ICHOM to be seen as a place that is not just talking about patient centricity, but actually living it. I hear and welcome ideas and feedback from patient communities to say, I like this, but do this more. That's how we get better at it.
I'm finding the work absolutely fascinating. Thank you for painting that picture, Jennifer. And I think it's extremely important work. I love the fact that patients can be on those publications, the end-to-end involvement of patients. It's everything this podcast is about as well. But I mean, it is something that we usually end up shouting ourselves hoarse about in general across the industry, across healthcare. There's a lot of tokenism to that concept, right, of patient involvement. But this seems to be a place where that's happening more holistically. I'd like to zoom in a little bit on the process itself. So can you just describe how it works, who initiates the generation of the patient-centered outcomes measures? What are the steps involved?
I think at the beginning, the choices about what sets to develop were really driven by big impact, right? So the oncology sets.
Right.
Yeah.
I think our first set was coronary artery disease. So thinking about the big disease prevalence. We still look at disease prevalence as one of the factors in deciding, but it has one of two pathways. Sometimes entities, whether it's an academic medical center or a government or a clinical group, will come to us and say, we'd like to develop a set family in X.
Yeah.
More often than not, we're looking around and saying, where is there disease prevalence that still is not represented in our library? So our library covers 60% of global disease burden right now, going on 48 different health conditions.
Wow. Yeah.
But not respiratory, inexplicably. So right now, our team is very motivated to identify where's the greatest need to develop a respiratory focused set. And we're trying to cultivate interest from people who could potentially sponsor that. So it's a bit of a mixing bowl to come up with what the topics are. But once we do and we have sponsors in place, we generally are running between a 15 and 18-month process to get from identifying the people who are going to be on the working group to publication. So the first thing we're doing is empaneling the working group, identifying a clinical and now a patient chair, and identifying a research fellow. We have an open call, a hiring process, so we don't just cherry pick. For the working group and paneling, we go to clinical societies and say, who should we talk to? We go to patient groups and we ask, who are the clinicians you work with? Are there patients that are interested in being involved? We ask clinicians if they have patient connections within their own countries. We look at multiple countries. So in every instance, we have global representation. We're striving for at least a quarter of the working group being lived experience. Sometimes we're lucky enough to find a clinician or a researcher who also is lived experience. And then the process is we gather, we're educating, we talk first about scope. So the whole working group has input into what's the scope of this set. Is it going to talk about adult and children? All of that. Yeah. And then we talk about dimensions of health. So that's really where the patient lived experience is such an important factor, because clinicians can speak to what they observe, but patients speak to what they live. So when I say dimensions, what I mean is like pain, mental health, sleep, functioning. That could be mobility, it could be ability to work, education, and then, the biological things like glucose management, lipids, blood pressure, survival. And then once we have the domains identified, then the research fellow really kicks in to do a lot of the literature search and bring back to the working group, here are all the metrics, irrespective of who built them. We put the whole list in the pool, and then we go through several rounds of prioritization. In every round, if the patients say that it should carry through, we generally carry through. Even when a clinician says, it's not so much. And that's an important thing to point out, because oftentimes when patients are in the room, their perspective may be diminished, but we understand it better. Yeah. And then when we get to a draft, through those Delphi rounds, we kind of narrow down to what's a comprehensive set. And then we put that out for 2 surveys. One is with clinicians, and that is about feasibility. So we want to hear from patients living with that condition who aren't on the working group to ask the question, does this ring true to you? Is there anything missing? Are there things on this list that are most important to you versus less important? And then we bring all that back and have one final round of fun to come up with the set. And then we write up the paper and we publish it. And sometimes we're expressing that there's a dimension of care for which there is not a measure, for example. That is a common scenario. And that's where the iterative part of what we do is so important. So we are looking at updating our sets constantly. We're looking at creating what we call a primary subset for some of our older sets. So they're pretty comprehensive. And one of the barriers we encounter is people look at them and go, oh my God, you want me to measure all that? Yes, but start where you are. And so the primary subset is really designed to say, like, if you can't do everything, start here and build. Don't let perfect be the enemy of the good, right? And once you get drunk on the idea that this data is gold, you start gaining momentum. And that's what I see every day, which is pretty exciting.
It was so interesting to hear about that process. And thank you for describing it in that way. It's really clear. And I love that the patient voice is really baked in at each stage. And I think that's really important. But also, we spoke about this on the podcast a few times. The patients are involved, but actually the process is also very scientific and clinical in a way as well, so that it can be accepted and adopted into that clinical community. And that's really important as well. And sorry to just jump back to the beginning, but I was interested to hear you talk about how you kind of decide which measures come across. And I think a large part of that sounded like maybe it was driven by who wanted to sponsor it and their priorities. So I wondered if I could ask who those sponsors typically tend to be.
It's a real mix, and I think that's one of our strengths as well. So sponsors of our sets have ranged from specialty clinics, clinical societies, governments. The NHS sponsored our entire mental health set family, for example, foundations, device companies, pharmaceutical companies. That's been more recent. I think obesity was our first set that actually had pharma support. But just to say, we take the notion of multiple sponsorship very seriously. So there's not sets that just have one per se. More recently, for example, the SMA set is also sponsored by the SMA patient organization. And I mean, we're talking like a token contribution to make sure that it's well-rounded, but it's just as important to show that they are giving input, not just from an expertise level, but from a sponsorship level. So for diversity, we aim for multiple sponsors, and sponsors have zero input into that whole process that I talked about. So they do not sit on the working group. They might give us recommendations for who to interview or consider for the working group, but we have the ultimate authority of deciding. We give process updates, but they actually don't see the content until we're ready for it to go. And that's on purpose, because it is clear in our agreements that thank you very much. You're helping do this. This is for the good of the world. We put our stuff out into the world for free. And your sponsorship helps makes that happen. Thank you. But you have no front row seat to it, because we need to keep it separate.
Yeah. That independence, of course, is really important for credibility, and also, again, for that sort of robust process to make sure that you're not saying the specific measure that this pharmaceutical company have used happens to be the one that we recommend.
No. At the end of the day, this has to be about, are we generating data that's helping us get patients better? And I believe that the sets have the ability to help all of us have more confidence in the science. So for example, our work is agnostic to intervention. So by that, I mean, you can use the obesity measure set to look at patient outcomes, irrespective of what treatment interventions used. So if you're a clinician and you're treating a whole group of patients, and some of them are getting bariatric surgery, and some of them are on GLP-1s, and some of them are on a more conservative, like lifestyle change, you can use the measure set to track all of them. And the beauty of that is not only are you focusing on waist circumference and weight loss and fat loss, but you're also focusing on pain, mobility, mental health, functioning. You can see how your total patient population is doing. You can see what's working better for whom. You can do comparative effectiveness research in real time. Think about the savings that we're creating in terms of insight and real learning for real world evidence that doesn't require $5 million massive grants and a 5-year research study. And I'm not dismissing the importance of those head-to-head trials, but we will all learn faster. Using common measures. And this is another big point that we make. Standardization is often used as a dirty word. Standardized means homogeneous.
It's boring.
Boring. Like it means rigid. You can't be flexible. And we are different. We have a different structure. We have a different payment. We have a different patient mix. It's all red herring. Standardized means we're all using a common metric to ask the same question. Why is that important? Because we will learn faster globally if we are all measuring things the same way. We can see faster where a hospital in Singapore is improving their outcomes for stroke patients compared to Brazil. And we can have a conversation that says, well, why is Singapore getting such great results? What can we learn from them? Healthcare needs and challenges are not unique to the United States, to India, to Singapore, to Brazil. We all have the same health conditions that are in the top 5. We all have workforce shortages. We all have rising costs and percentages of our GDP that are being spent on healthcare. And we're all getting sicker and older. So it doesn't matter what country I go to, it's the same narrative, which means we need a common solution that helps all of us.
Yeah.
And we can learn faster when we have data that allows us to compare.
Yeah, I think that makes a lot of sense. I wanted to move back a little bit to the patient involvement aspect and understand whether the patients who get involved need to have any specific qualifications and how they might find out about such opportunities.
Great question. First question, no. I mean, obviously, we have all kinds of patients come. Some have degrees and some have degrees in life, and both are relevant. So really what we're looking for in a patient who is participating in a working group is two things. One, lived experience in the health condition. We all have seen examples where patients are on a advisory board and they don't actually have relevant experience in that condition. That's no. That can be current or prior lived experience. So sometimes, like in our oncology set, sadly, some of our patients that were involved in the original set have had recurrence and cannot be on board. And that breaks my heart. But that's a natural part of involving patients in what we do. And so we just need to think outside the box and be open to how do we accommodate that. And then the second thing is really interest, like really understanding what the process is, a willingness to be on this journey with us, a willingness to ask questions and know that they are empowered by our team and by the commitment of the chair. We look for chairs who have had experience with patient organizations, and we do whatever we need to do to help the patients that are involved feel equipped and ready to play. And we also compensate our patients. All of our working groups are volunteer. If you're listening and you're in a working group, thank you very much for your service. Except for patients, we do compensate them using the National Health Council calculator. We believe that patients should be paid for their time because they're not on a clock that other experts might be.
That's really fantastic to hear. We're completely aligned with properly compensating people, for the value that they can bring in their time as well, especially if people do happen to be dealing with a health condition at the same time. And I was going to ask if, even though they don't need a qualification, do they kind of need knowledge or experience of the process? But it sounds like actually that's something that you would help to provide them. Actually, all they need is kind of the willingness to jump in, get involved, share their insights, collaborate, and essentially making sure that they're in the room and providing their insight.
Yes, exactly. And I think every time we have it, we're learning something new. We're thinking about what are better ways we can prep any patient coming, irrespective of disease area. But I think our team has gotten really good in really explaining what we're doing. And we end every working group with trying to get some feedback. What can we do better? What went well? That kind of thing. And then when I joined, we started something called the Patient Partner Alliance, which is a free to join group for us to bring together different patient communities. And it's really about helping them understand, what do we mean by outcome measures? What is this process? What is it that we do, not to indoctrinate, but to aid? Like, how can we be a resource? How can we listen to what your needs are? We go to the Patient Partner Alliance when we're publicizing the validation surveys, for example. We put them out on socials. They're publicly available. They're on our website. We do a lot. However, I know from personal experience, it's the army that gets you farther, right? So the more connections you have, the more it proliferates. So the Patient Partner Alliance is also our distribution network. SMA is not a topic that all of our patient organizations that work with us know about. But what we ask them to do is to try to see, is there anybody in your network that could pass it forward? Yeah. And the other thing is we have a conference every year, and I'm very proud to say that we've increased the patient, not only participation, but putting them on stage. People from our working groups, put them on stage and say, talk about your experience. What's been transformative about this? Why do you believe this is what we should be doing? What did you learn? What do you challenge us to be? And that's been new, I think, a little bit for this community, because our traditional community at ICHOM has been largely clinicians. And the clinicians are definitely there for their patients, right? They're in this field because they feel very passionate that they want to achieve better health for their patients. That's why they show up to what we do. There's still old habits about what the roles are. And I think my orientation and my colleagues are trying to activate we're in this together. And when we have the power couple, being the clinical team writ large, not just the doctor, but nurses and allied health professionals, but that clinical team plus a patient that is able to say, well, you talked to me about these three things, my glucose level and my lipids and blood pressure, but I want to talk about this. My diabetes is preventing me from getting back to riding horses or playing soccer at the level that I want to play. And you're talking to me just about my time in range and nagging me about my diet or whatever. I want to get to this. That's a different conversation than a lot of clinicians perhaps were trained to have. But again, this is about transformation and fundamentally changing the way we're talking about health.
That's so interesting, Jennifer. So we've had a few conversations, and it's a topic that's really hot at the moment and comes up. That's about shared decision making. And shared decision making feels very much like it's the in-clinic version of what you're saying, which is when a patient's in front of you, what do you need to discuss with them and what might they consider to be valuable? And actually pulling that back and having kind of an official measure to say, don't only look at those clinical steps, but actually consider broader about impact on mental health, lifestyle, those kind of things would probably equip healthcare professionals for those conversations in the clinic as well, because they're seeing that broader scope of evidence and data instead of just those more traditional clinical measures.
So one of the delightful things, and I haven't yet figured out the right way to capitalize on this, but I'm always thinking forward in this regard. We have a peer-reviewed journal article. We have case mix variables. We have a data dictionary, which is very nerdy, scientific. What are all these little pieces of the measures? But a patient who was on a working group not too long ago said the most valuable piece of the whole set is that flyer. It's a 2-page, shows you who was involved in building this. And it's a wheel, this colored wheel that shows here's the condition and here's all the dimensions of outcomes that we're talking about. And then here are the tools. They said before, when I go into my clinician, they're driving the, what are we talking about today? I could bring this flyer in and I could say, well, you talked to me about this, but here's what I want to talk about today. And it's like,
that's amazing.
Because I was like, okay, that's awesome. How do we make that be a tool that patients can use to change the conversation? Because I agree with you, shared decision-making, I think, started with the right intention, which is equal footing. More often than not, I'm hearing about it as shared decision-making leads to better patient engagement, better adherence. That's a generalization. So I'll just say not always. But that's not the purpose of shared decision-making. Shared decision-making should be about bringing information back to both parties, clinical expert and the patient expert, and allowing that information to elevate the conversation relevant to that individual in the room. And again, if we're measuring using standard metrics that have international consensus, scientific basis, and the blessing and thumbs up from the people who are living with the condition, that generates information that serves both parties better. Then you can see, well, how is this clinician's patients doing overall? And you can see, like for myself, on average, people who are living with diabetes in my age bracket with my history are more likely to be in this range over time. And then here's what my numbers look like. And what that activates is a conversation about, well, why am I not getting to where I'm trying to go? You can't get to the why questions if you can't see information. And outcomes information really does open up a different conversation for the clinician and the patient on equal footing. So what we're talking about is outcomes-driven shared decision-making is an order of magnitude from where we are right now, which is shared decision-making based on clinical expertise, based on compliance and adherence. That's not what I think patient communities want. And I think it keeps us trapped in this old dynamic of clinician before patient.
That's so interesting. And that makes me feel like most in-clinic conversations exclude statistics. I've hardly ever heard clinicians say this percentage of patients tend to do well on this. Unless they're offering you a drug on which there is published data. It's such a narrow situation for you to have a benchmark, for you to have any kind of comparison, which is so important for chronic conditions where everything is on a spectrum and you want some sense of how bad is my arthritis. For someone my age with my lifestyle, how bad is this? How bad am I going to get? I think that that perspective is missing, and that's such an important thing, which makes me feel like this should be everywhere. It should be in all hospitals, in all clinics. It should be everywhere globally. And that leads me into the next segment, which is barriers and challenges. So how is the adoption? Is there opportunity for these patient-centered outcomes measures to be adopted universally in all disease areas, regions globally? How does adoption look?
Yeah. Okay. So there's now and there's where we could go. One of the things that we've done since I joined is get better at tracking where our work is in use. A lot of that is self-report, so it's a bit slow going, but we can track that over 600 different health entities, that might be hospitals, health systems, small clinics, are using ICHOM sets as a backbone for data, some in pilots, some in routine use. I think our count is 47 countries right now. We have an implementation map on our website that you can see, and you can hover over different pins and see what the organization is and what they use. Not perfect, but it is a good pulse of the fact that we are used globally across many disease areas, but it's not universal. The exciting thing is that the pace is accelerating in a couple of ways. One, I'd like to think that we're doing a better job of publicizing and talking about this. But here's what's changing. Now we have whole governments talking about this. The Swiss government has said this is going to be part of our national quality strategy, and measuring outcomes is the backbone of that. NHS is resurging in their focus on, 10-year care transformation, and they are talking about outcomes. Even CMS here in the US is starting to dip its toe into patient-reported outcomes. Now, I'd personally like to see that go farther, but it's a signal. And we also have payers, international payers and employers who are starting to look at this and realizing that data that's about outcomes, are we getting the people that we pay for healthier, is a serious lever for their interests, right? There are examples in every region of the world, Far East, Middle East, Africa. Some of the most inspiring examples are in Africa. They start on paper collecting this, but they're moving to whole country strategies on improving pregnancy and childbirth outcomes or diabetes outcomes. That's transformation there.
Wow.
So the good news is when I started 3 years ago, it was very sporadic, maybe is the right word. And now I see starting whole systems. And I also think one of the things we do a lot of is educating. So we have a webinar series where we showcase really positive examples and we put that out there. And traditionally, we're getting hundreds of people on these webinars from like 30, 40 countries. So the hunger level for tell me where it's happening elsewhere and inspire me. Oh, I can do that. Oh, I can bring back this example to my CEO and my CFO. And I can say, well, if they're doing it in Singapore and here's a roadmap of how they did it, we should be able to do it here. And I think the next rung up the ladder is benchmarking. Like, how do we create a platform and data that allows Thailand and Singapore and Brazil and the US and Netherlands to compare common data and see what are we learning from each other about how to do this work, how to implement it, how to change care pathways, things like that. So ICHOM is also hosting learning collaboratives on both breast cancer and obesity treatment with that in mind, to try to model what can we do across boundaries that help us all learn faster.
This is supposed to be the barriers and challenges segment, but you've made it all sound so hopeful.
Let me just be acknowledging, because there are barriers, right? So barriers include, we are trying to move the Titanic of traditional model of care to something that's truly patient-centered and transformative. That's hard. It requires leadership. But down at the granular level, it takes intensity and intention to measure things that are important to patients. That requires change in systems, that requires personnel, that requires data structures. Those are not easy things. What we're trying to send the message is that it's worth the investment. When you do it, you actually might be using your nursing staff in a different way, and it might be more intensive. But what you gain is you're able to treat your patients better. They get better faster. That makes room for taking on more patients. It's not a one squeeze. It's like the whole thing kind of shifts in a positive way. So of course there are challenges, but frankly, There are barriers to access, right? We have people in some countries on waiting lists for basic things, basic surgeries or for getting devices or whatever. We need to use our resources more wisely to get better outcomes for less squeeze. And that makes room for access. That makes room for innovation. That makes room for better population health strategies. All of these things, we need room. And every single country discipline is challenged by we've got more and more and more need and shrinking workforce, and we're not hitting the mark on better health. So something's got to give. I'm not dismissing barriers, but I choose to say yes, barriers, and here's why you need to just punch through them.
Yeah.
I love that. That's great.
Love that. Yeah. Sorry, I just have a quick follow-up question on the adoption point. Who would you say is responsible for adoption? Is it hospitals or governments, or is it just situational?
Maybe my answer sounds too general, but I think everybody's responsible. So everybody has a role to play. I think largely this movement, this notion of outcomes-driven care has largely been championed by a clinical community first. And that's not wrong. Clinical leadership is really essential to this taking root, not just at the specialty level, but at CEO, CFO, C-suite level. And we're seeing growing recognition of that at C-suite level. But payers have an obligation to understand this and embed it in their work. Governments have a responsibility. I mentioned some governments that are starting to realize this can be a national strategy. A growing conversation that I'm having is with major employers who are the primary purchasers of healthcare in most jurisdictions, irrespective of payment system. And they have workforces, and their workforces are the ones that aren't getting better. And that has an impact on employer bottom line, right? Productivity, their total cost of care, things like that. They have a lever. Employers can expect that the payer systems, the clinical systems that they pay can deliver better outcomes. And the outcomes that we're talking about are a bit of a resource, right? If you want to know what key performance indicators you want to embed in your contracting, here's a gift. And we're starting to see interest in payer and employers in this concept. What is it? How can it serve everybody's needs? And I'm not naive. Each of those actors have their own what good looks like. But that's why I say it's everybody's responsibility, because the minute you just make it one, then everybody says, well, I don't have to do this. I absolutely think that's anathema to the concept of value-based healthcare. It's a team sport, and everybody has a role to play, making the system change and ensuring that patients get back to health.
Yeah, that makes a lot of sense. And actually, we feel like the theme for 2026 is that collaboration across different stakeholders, because actually the system is made of so many different groups with different priorities. But overall, everyone's trying to improve health. So where there are systems like this, where it requires everyone to be involved and implement it to make it happen, then that's great. In a way, I was almost thinking about it from what you were saying about, while I guess researchers and clinicians would be maybe implementing the outcomes measures, it almost relies on that motivation from kind of further down the line, the payers, the governments, to say, this is something that we will recognize and we find important, so that it gives clinicians and researchers the motivation to say, okay, further down the line, this will help us demonstrate the value of what we're doing in a way that later stakeholders recognize. And then overall, because it's patient-centered measures, it will help the patient to get to that final point, which is actually access to the care they need, or evidence to demonstrate that this is something that's worth people investing in, this is something that should be prescribed, or another intervention that should be used. So it makes sense for everyone to be talking about this together in a collaborative way.
Yeah, it's the ultimate aligner, right? We talk a lot about, especially here in the US, about misaligned incentives. And I'm kind of tired of hearing about that, because it's almost like we're saying it's an excuse. Well, these are misaligned incentives and we should just accept that this is the scenario that we live in. Come on. This is the aligner. Doesn't matter who the player is. If you're all focused on, does this intervention, does this strategy, does this payment, does this benefit design, does it help deliver benefit to the patient? If you can't answer yes, Clarinda, you asked about How do we bring statistics back in?
Mhm.
I think that's the positive opportunity with AI. I think AI right now is not trained on this kind of data, which is a little bit concerning. So AI models are trained on data we have right now, which is about bad outcomes, right? Claims data is evidence of poor outcomes often.
Yes.
And so if we're training these algorithms to give back answers or options based on that, I'm a little afraid about that. However, AI also on the positive side has the opportunity to reduce the friction of collecting this data. It has the opportunity to bring the insights that outcomes-based data can bring into the clinical moment. How do we leverage the positivity of these tools to make it easier to bring it back to the patient? That's the challenge, I think. That's what I'd like OpenAI and Anthropic and all the rest. Don't tell me what you can already do. Tell me what you're going to do with this that's actually going to change the conversation. I'm a little bit rebellious.
I like it.
So, Jennifer, I think this has been a really fascinating conversation, really enriching as well. And I think that you've given us some really meaningful things to think about for healthcare holistically. And I think you might have preempted my next question a little bit when you spoke about AI, but we'd like to understand how you imagine this space of health outcomes research and health outcomes measures evolving in the next 5 years.
I mean, I think my optimistic view is that this is everywhere. I'm pleased to be able to say that ICHOM's work is being used on all continents in a huge number of countries. And I think our ambition is that it's everywhere. It's the backbone of data that helps us inform national population health strategies all the way down to clinical care pathway design, that it's the backbone of what value-based payment looks like. So in the next 5 years, I think AI and a wider understanding of the impact of outcomes measurement can help proliferate even more. And that's, I think, what we would like to see at ICHOM. Because when we do that, we create data systems that can talk to each other. We can learn on a global level what works for whom. And I think ultimately improve patient health over time. And that's what we need to be striving for. So let's talk in 5 years and see where we are.
Yeah.
I believe it though, because I've been at ICHOM for 3 years and I've seen a market shift from this being a really niche like group of people in the know to now we're widening the tent. There's more people showing up. There's the engagement with patient communities. The more we proliferate and kind of share this vision and where it's in the world, I think the more it will take root. And that's what's needed in order for it to become more than just a conceptual movement, but to actually be the data that drives better health decisions globally.
I've really loved this conversation, Jennifer, because we asked that question, but actually this whole time you've kind of been looking forward to the future. And like you say, the ball's already rolling and outcomes measures are being developed. They're already starting to be implemented. People are starting to share how they've done that much wider. So that'll have a knock-on domino effect, especially if you can demonstrate that value and that improvement in health in a population. More people will take it up, and this is an international movement. And I do think it's also been quite a hot topic. A lot more people are talking about outcome measures, which is great because 5 years ago, people might not have really known what it means. So this has been a really hopeful and inspiring conversation. And I truly believe that you'll achieve what you've set out to achieve in the next 5 years. And I'm excited to see it.
So just before we wrap up, we just like to get your advice for patients who wish to be involved.
If you're interested in being part of the work that we do, definitely get in touch with us. Just make yourself known so that we can guide you. We can give you a sense. We also understand what you're interested in. We have a website, which can be a bit overwhelming with the depth of resources, but our sets are all available. We have the Patient Partner Alliance, which any entity and individual is welcome to get involved in if they desire to. It's not a heavy lift, and it's really about informing and sharing knowledge. We have webinars on a monthly basis that are open to the public. There are myriad ways you can learn about us and also raise your hand to say, for example, anybody on this call that's interested in respiratory or women's health, these are the sets that we're kind of trying to build sponsor interest. But if you have interest in these topics, let us know, because when we have the critical mass of partners, we're going to come asking for people to participate, and we will gladly welcome you. Oh, and definitely take a look at our conference. We have an annual conference. It's going to be in December in Montreal. I can tell you the patient communities that have come to the conference have been just delightful and delighted with the environment and the welcome. And this is an international community that's really making change happen. So it's really special energy. And also give us feedback. Caitlin, I'd love if you took a look at the diabetes set and told me what you think of it. I welcome that every time I interact with somebody. I'm like, take a look. Give me your good, bad, and ugly. That's how we get better.
Absolutely. I'll take a look.
Thank you so much, Jennifer. I feel like I've just left this conversation feeling extremely optimistic and hopeful about healthcare in general. So thank you.
Thank you both. Thanks for the opportunity. A great conversation. I enjoyed it thoroughly.
So, Caitlin, on the back of that conversation with Jennifer, which was really insightful and interesting, I thought we could just chat about what we learned and some of your top takeaways.
Yeah, so I think firstly, when you talk about outcomes measures, it sounds quite scary, technical, jargony. But what Jennifer really highlighted today was that actually outcomes of any kind of health intervention are things that everyone's already aware of. Things like, do you live longer? Does it impact health measures such as blood pressure or weight or blood sugar? Those kind of things. But also, how does it make you feel? What's the impact on your mental health? What's your mobility, side effects, just basically anything that could result from an intervention. And traditionally, it was focusing on those clinical aspects. But when we're talking about patient-centered outcomes, it's the clinical plus those more sort of day-to-day things. And actually, what Jennifer was talking about was working with patients to make sure that those outcomes are being captured and measured, so that actually, as well as understanding how it impacts your physical health, you can understand how it impacts your day-to-day life. So even though it sounds quite technical and they may be measured in quite a technical way, what we're talking about here when we talk about outcomes is just that everyday lived experience.
Yeah, and apart from the definition, which I thought was enlightening in itself, I found the point that she made about standardization really interesting. We talk a lot about diversity and the case for individualization and personalization in medicine, which is fair and that's needed. But there is also a strong case to be made for standardization, which helps comparison globally across regions and across health systems within disease areas. And that was a really interesting point for me.
Yeah, and I think to follow up on that point, we had a really interesting conversation about how that can support real shared decision making, because actually it's not just based upon the evidence from the trials that's available about which intervention is best from a clinical standpoint, but can actually provide that meaningful evidence around what matters to patients as well. So if what matters to you, for example, is mobility, and there's a measure that measures that outcome for you, then you can actually use that to compare different interventions and see which withholds that for you. So even though there'd be a standard set, you can sort of pick and choose that based on, as an individual, which of these measures and outcomes matters most to me, and use that to support with shared decision making. So it's providing people with more of that evidence that actually matters to them.
Yeah. So it's actually applying the standardization for individualization, which is so cool.
Yeah,
and I think just to sum up, ICHOM is doing some fabulous work in creating these standard sets of outcomes measures for disease areas. And we hope to see more disease areas getting covered. We hope to see more adoption globally and definitely more patient involvement across the spectrum.
absolutely. Thanks so much for listening. This has been Not Just Patients with our guest, Jennifer Bright, and your hosts, Caitlin Rich and Clarinda Sarasia.